One of the other things to remember about retroviruses in general, but also just even thinking about HIV specifically, is that the reverse transcriptase enzyme is very error prone. So they estimate up to 5 errors in 9,000 base pairs, so in the whole genome. And that might not sound like a lot, but when you think about the human, our DNA polymerase to replicate our genetic material, we're talking about maybe 1 error every 1 billion base pairs. So DNA polymerase is got a very high fidelity. Reverse transcriptase is very error prone. And that can be very good for HIV because it promotes new strains and additional immune evasion. So basically, once your immune system has learned to recognize a version of HIV, you no longer have that same version. This makes it very difficult to track where an infection came from if it's been too long since the infection was first acquired. Because let's say you have person A and person B. Person A has HIV, and somehow either through like sharing of needles or through unprotected sex, person A gives HIV to person B. And person B finds out they have HIV. They're like, I'm really sure that person A gave it to me and I'm really mad about it. But depending on how long it's been since that transmission of the virus, sequencing might show that they look like 2 completely different HIV strains, even though they were originally the same because of that high error rate. Okay, so what happens when a patient has HIV? So you have infection. This is looking at sexually transmitted infection, but again, it could also go directly into the bloodstream through infected needles or things like that. It will get into cells of the immune system, eventually into the lymph nodes, and a patient will have a relatively high viremia and experience what's called acute HIV syndrome. So this is flu-like symptoms that show up within weeks of the initial infection. So patients will feel sick, but they won't probably know that it's HIV. Rarely, some patients may develop mild disease in the central nervous system, but more likely what's going to happen is those flu-like symptoms will resolve and a patient will remain asymptomatic for a very long time with a steady level of HIV in the bloodstream. But eventually things change, and patients will start to have swelling in the lymph nodes because the virus is now targeting different cells, that CXCR4 receptor. The viremia will again go up, and this time what happens when the virus load goes up is there's a huge drop in the number of CD4 positive T cells. We also will see a drop in the number of CD8 positive T cells. And when we get to a certain level of CD4 positive T cells and we begin to see the presence of these opportunistic infections, that's when we say a patient has progressed to AIDS. So you have very strange fungal infections, reactivation of latent viruses, so herpes viruses, including zoster, Epstein-Barr, anything that your body has been able to control, it no longer can. And then you can have the appearance of viral-related cancers. So one of the herpes viruses that we didn't actually talk about is one that causes a disease called Kaposi sarcoma, and it causes basically tumors to form all over the body. If you ever saw the movie Philadelphia with Tom Hanks, there's a scene where he's in a courtroom and he opens up his shirt and he has it's about a lawyer with HIV, and he has the Kaposi sarcoma on his body. And this is generally when the patients will die, not directly of HIV, but because of the significant immune deficiency, they'll most often die of a different infection. Some patients can also develop AIDS-related dementia, where the central nervous system and the brain just experience too much damage. So the virus can kill cells through syncytia formation, through cytotoxic T cell mediated cytolysis. So basically the CD8 positive T cells will try to kill infected cells. And sometimes cells can undergo what's called inflammatory apoptosis or pyroptosis. And so normally when a cell undergoes apoptosis, it will kind of package everything really neatly to try not to cause damage to other cells nearby. But in this case, the cell is basically like, nope, we're having a problem, let's go. And just it'll undergo apoptosis really quickly. That can cause some inflammation in the nearby area, which will then recruit other T cells to the site of infection, allowing them to be infected. And that pyroptosis is thought to be induced during the stage where the viral RNA has been reverse transcribed into DNA, and that DNA has become circular before it goes into the nucleus. Our cells are not supposed to have free-floating circular DNA in the cytoplasm. That triggers the cell to be like, something is wrong here, and that's why it'll undergo that quick apoptosis. So these are, some of the things that can happen to help HIV evade the immune system. They infect immune cells. They have mutations of their proteins that allow them to evade antibody detection. They can modify their proteins to evade antibody detection, and they can spread from cell to cell directly, which can also allow evasion of antibody detection. Those of you who know Dr. Gousset, she studies these really cool structures called tunneling nanotubes that connect eukaryotic cells, like our cells, to one another. And HIV can use those to go from cell to cell without being exposed to the immune system. So again, what we're looking at is the course of infection. So a couple of things I want you to look at. Virus load is here in this kind of gold color. So early in the infection, you have that acute infection where you have those flu-like symptoms, and then the viral load goes super, super low. And eventually, months, years, this number can be very variable. Those numbers will get higher and higher for the viral load. We can also look at the CD4 positive T cell count. Normally it's pretty high. It'll dip during that acute infection, but then come back up. And now the problem is that slowly those numbers go down and down and down and down. And at some point, the virus is so high and the T cells are so low that you now have that immune suppression. So what we have happening, again, this is our major cell type that we're infecting. And this cell, this CD4 positive T cell, is responsible for producing all of these cytokines, for the growth and control of B cells, the growth of natural killer cells, other CD4 positive T cells, and CD8 positive T cells, activation of epithelial cells, neutrophils, and macrophages, growth and control of innate and immune responses. And so basically you're taking this out, you're taking everything out. So you wipe out the immune system. HIV is an infection that we do see worldwide. The highest incidence is in sub-Saharan Africa. Some of the lowest incidence is in the Eastern Mediterranean, what we would call here like the Middle East, some parts of North Africa, even parts of the Western Pacific and Southeast Asia. Europe have lower levels of HIV than the Americas as well. So Africa and then the Americas have the highest prevalence of HIV. I think we all probably know the routes of transmission. Again, inoculation into the blood, and we typically see that in patients who are sharing needles, so intravenous drug users who share needles. It could theoretically be also healthcare workers could be exposed. We tend to not see it through transfusion of blood and blood products anymore because of the huge amount of screening. Tattoo needles are also possible. but most tattoo parlors should have an autoclave, so we shouldn't see that happening really. Sexual transmission, super, super common. And then, of course, a pregnant woman can transmit either during childbirth, during pregnancy, or during breastfeeding. Routes not involved in transmission, household members or healthcare workers not exposed to blood. So there was a lot of misconceptions going around about HIV, even when I was little, like in the kind of early 90s when I was in elementary school. But by the time, like mid to late 90s, so by the time that I was in like junior high or high school, we knew that it was, you know, either unsafe sexual practices or, you know, some sort of bloodborne contact, that it wasn't like a hug or living in the same house or anything like that. But there were, you know, children like hemophiliacs who had HIV that were children that weren't allowed to go to school anymore because people were afraid that their kids would get AIDS from the sick kid. Like it was really awful for patients who had HIV. In a lot of hospitals, healthcare workers didn't want to treat the AIDS patients. It was very isolating. And so now that we have a lot more education about it, a lot of that stigma has gone away. So some of the opportunistic infections that patients can get are listed here. I'll let you, you know, kind of look at this at your convenience. But, you know, cancers, Kaposi sarcoma, HPV-associated cancer, non-Hodgkin's lymphoma, lots of fungal infections, protozoal infections, some of these viral infections. So lots of weird infections or infections that shouldn't make people sick but actually do. So the initial symptoms in that acute phase of the disease resemble the flu or even kind of like mono, and they'll resolve after a couple of weeks. And so most patients won't think, flu-like symptoms, I probably have HIV. They'll think, flu-like symptoms, I probably have the flu, especially because it goes away. A clinical case is considered to be AIDS when the CD4 positive T cell count is below 200, the viral load is above 75,000, and there's the onset of a significant disease. So that's when you would classify a patient as being an AIDS patient versus an HIV patient. So this is a case study of an early case of HIV/AIDS, very early. In July of 1981, a 27-year-old man complained of painful urination, fever, chills, night sweats, weakness, difficulty breathing, cough with sputum, loss of appetite, and a 16-pound weight loss. For the past 7 years, he had been receiving up to 4 monthly infusions of factor VIII concentrate to correct his hemophilia. It's factor VIII is something that helps with blood clotting. So hemophilia is a blood clotting disorder. He did not have any risk factors for HIV. So in the 1980s, what they're trying to say is he didn't use drugs and he wasn't gay. In August, pulmonary infiltrates were visible by chest x-ray. In September, they give his specific blood results. IgG was present to cytomegalovirus, to Epstein-Barr, toxoplasma, and hepatitis B. An immune deficiency was suggested by a lack of response to like the tuberculin, mumps, or candida skin tests. We talked about, of these, we've talked about the tuberculin skin test. It's the PPD. So he didn't have a response. They identified a super weird fungal infection, very uncommon, in a stain of his lung biopsy. So they started treatment. Then he developed thrush, which also prompted treatment. So thrush we'll talk about when we talk about opportunistic fungal infections, but it's an overgrowth of a yeast called Candida albicans in the mouth, and you can actually see it. It's like a white coating on the tongue and on the surfaces in the mouth. In May of 1982, so almost a year later, he developed an enlarged spleen and lymph nodes. So he went back to the hospital. His leukocyte count dropped in half. So originally it had been 4,200, now it was 2,100, and only 11% were lymphocytes. It had been 36%, so they went down by almost 2/3. At this time, he was infected with Mycobacterium avium, Again, very weird bacterial infection, very uncommon. And then his total lymphocyte counts were 448 compared with a normal count of 2668. In July of 1982, so a month after his initial contact with the physician, the total lymphocyte count was 220, 45 CD3 positive T cells, and a CD4-CD8 ratio of 1:4, meaning he had really low numbers of CD4 compared to CD8 when they should be very similar. Or actually when you should have more CD4 than CD8, excuse me. So he had basically one CD4 positive T cell for every 4 CD8. He should have had 2 CD4 for every 1 CD8. He continued to deteriorate, and he died in September of 1982, so just over a year after he initially came to the hospital. They isolated cytomegalovirus from his lung and liver, that mycobacterium from most tissue samples. In 1981, AIDS was a newly described disease, and HIV had not been discovered. So again, we're talking about AIDS was discovered first, this acquired immune deficiency. The virus causing it was not discovered until later. And so basically what had happened is that patient had acquired HIV infection from his blood transfusions before routine screening of the blood supply. So this is why hemophiliacs were included in that group of individuals who had developed AIDS. There are a number of diagnostics. There are some really rapid diagnostics now where you can go and do a 20-minute test and they'll determine whether or not you've got HIV. If you are positive on one of those rapid tests, they'll do another confirmatory test to make sure. They'll also want to quantify the amount of virus you have in the blood if you are positive. But unlike in the 1980s, we now have therapies that are available. And as I asked you to think about kind of at the beginning of this, some of the therapies include inhibiting where the cell binds. So can we block CCR5? Can we prevent fusion or penetration? So interfering with again, CCR5 or the HIV protein GP120. Can we inhibit the virus's integrase, proteases, or the reverse transcriptase? So now patients who are diagnosed with HIV will generally be prescribed what's called HAART, highly active antiretroviral therapy, which are some combination therapies. Education is the primary infection control. So, don't share needles with people, don't engage in unprotected sex. Blood product screening helped for anybody who needed blood transfusions. For healthcare professionals, of course, you should always be wearing PPE. Any surface that gets contaminated with bodily fluids should be disinfected. It is an enveloped virus, so it should be pretty sensitive to most standard disinfectants. There are no vaccines available yet, but there are a number that are in development. So groups like Moderna and Pfizer that have made some of those mRNA vaccines for COVID are working on mRNA-based vaccines for HIV as well. And you may have seen commercials for it, but there is a drug called PrEP. That's its abbreviation. The drug name is Truvada, and PrEP is an acronym that stands for pre-exposure prophylaxis. So the idea is this is generally prescribed to men who have sex with men, whether or not they identify as gay or bi or, whatever, but people who, again, men who have sex with men is the most common group that this would be prescribed to. And it's a combination therapy of 2 reverse transcriptase inhibitors. And the idea would be that patients who engage in these high-risk sexual activities can take this drug to hopefully prevent the development of infection. And it actually works pretty well, but the problem is now that people have this drug, so they're not worried about HIV, they're not having protected sex anymore, so other STIs are at a higher level in these patient populations. So it's still important to protect yourself. And finally, circumcision has been demonstrated, at least for men, to reduce the risk of HIV infection.